On the Conn Job, I welcome Willem. He's a leading interventional pain doctor in the Netherlands, where he works in their national healthcare system. He's also a lecturer in London, an academic lecturer about the research he's done. He is a leader in organizing meetings in Europe in the specialty of interventional pain. He was trained in the Netherlands in anesthesia and then did a specialization in interventional pain. He's done research in spinal cord stimulation and in treatment of lumbar discs with injection. So he's going to help us understand how the system works in Europe as compared to our system, and talk about some of the leading topics in our field and how our field is going to evolve over the next few years. So thank you for joining us today, Dr. Kallewaard. I appreciate it. I know your schedule is very busy. So I'd like to talk about what it's like to practice in Europe, because I know you're in two different systems. You practice in Amsterdam under the EU system and in London. So could you please tell us, summarize your education, and then tell us how you set up two different practices in different countries and systems, please.
Okay, let's start with my name. My name is Willem Kallewaard. I come from the Netherlands. I've been trained in Utrecht and also did my specialty training in anesthesiology there. And then during this training, I got interested in pain medicine. And after my training, I started working in Arnhem, which is in the east in the Netherlands. Still work there. And I also worked since 7 years in Amsterdam in the University Hospital. And since 2 years, I'm a lecturer in London, which means that I'm not actually having practice there.
I see. So you're just an academic there, presenting research, because I had seen you've done research a lot on spinal cord stimulation and treatment of the discs, which is fascinating. Is that mainly what you educate? Are you educating the residents and fellows, or what is your role there?
Yeah. Mainly how to perform scientific research. And then if you look at the scientific goals, it is low back pain and discogenic pain, and spinal cord stimulation, and especially the new indications for spinal cord stimulation.
Right. So in your system, do people do a fellowship after anesthesiology, or how does that work?
Yeah, so up until 4 or 5 years ago, it was a fellowship after the training. But nowadays, after 3.5 years, you can choose for this fellowship. So you do it during your training.
I see. Okay, that's good. Do you feel that people get adequate training when they take that pathway?
I think they do. It's a combination of university training and training in a peripheral hospital. And when you finish your training, within 5 years, you have to do the EFIC exam and VIP exam of the WIP.
Right. To get board certification, we would call it. Is that board certification that you achieve? Okay, I didn't know the initials. Did you say FIP? Can you explain that, please? Offer clarity.
So the WIP is the World Institute of Pain.
Yes.
And they have the exam of interventional pain practice. It's the FIPP.
Yes, I'm familiar with this. Some American doctors do this also. Yeah, they do it in parallel to the requirements that we have. So in your system in the Netherlands, how do patients get to you? Like, what is their pathway to get to your care?
There's several options. One is through the general physician. They can send them to us, and eventually more and more after they call us and we have an advice, because we try to keep the patient with the general physician. But if we see an indication, it can be sent to us. And then lots of patients are referred by other specialists: neurologists, orthopaths, rehabilitation, rheumatology, surgeons. And sometimes it's also the patients themselves.
So they can directly refer themselves.
They can try, but we need a referral from another physician because of insurance.
Yes. So everybody, are they they all on public insurance through the government?
Yeah.
Okay. So the most common pathway is through the primary care doctor?
50-50.
Okay. So do you actually have a conversation with the primary care doctor on the phone, or is it done through messaging?
Yeah, since only 6 months. It's through messaging. It's an official system,
Yeah.
and when I spend time there, I can even send a bill for that.
Okay, so that's very interesting. So the bill, do the patients have any out-of-pocket responsibility, or is it all covered through the government health care?
It is all covered, but all patients every year have their own risk, and it's about in euros 385.
Okay, so their total out-of-pocket per year is about 385 euros, no matter what their medical condition is, even if they get cancer or something?
All of them.
Wow. Okay, so just continuing on that primary care route, how long does it take the patient to actually get to you after you agree to see them with the primary care?
Yeah, that differs per month. At the moment, the waiting lists are short, 4 to 6 weeks.
Okay.
And we have acute indications, so we'll see them within a week.
What are your acute indications?
It's cancer. It's facial pain like trigeminal neuralgia. It's an acute herniated disc.
Acute dislocation? Is that what you said?
Herniated disc, sciatica.
Yeah.
It's acute zoster. Those are probably the indications.
Right, shingles. We usually call
it shingles.
More commonly known in America as shingles. So have they already gotten MRIs before they come to you?
Not all of them, but most of them.
So when you get an MRI, is there an approval process? Can you get it right away? How does that work for you?
Can get it right away.
Like the same day?
If I want it the same day, I need to call the radiologist.
Okay, so that's impressive. Okay, because patients wait more here when we do need MRI, because many of the private insurers actually make the patients wait for 6 weeks unless they have a neurological deficit or cancer. So patients do wait. It sounds like you guys don't have that problem. Is that correct?
Not 100%. Because we get most of them referred by the neurologist, which means they come after a few weeks of pain at the neurologist. They make an MRI the same day, and then if it's a good indication, they send them to us.
Okay, so once you see them and do the consultation, speak with them, examine the patient, how long does it take you to get them on the scheduled procedure, just an injection type procedure?
We do it the same day.
So when you have to move to one of the advanced treatments like spinal cord stimulation, can you explain the pathway for the patient, like what they have to have done before they can have spinal cord stimulation, and then how long it takes to get scheduled?
Yeah, can do that. So at first, it needs to be an indication that is reimbursed in the Netherlands. There's a difference between the US and the Netherlands. So we have reimbursement for failed back, failed neck, CRPS, polyneuropathies, but not for angina, not for abdominal pain, and not for ischemic pain. But if we have a patient with a good indication, then we need conservative care to be not positive, not effective, anti-neuropathic patient not effective, minimal invasive treatments not effective, and then it needs to be a good psychological profile, needs to be approved by our team. Our team is also with an orthopath, neurologist, psychologist, and our team. And then when we see it's a good patient, they get their first intake. From the first intake, it comes back to the team. and then we plan the patient, and we all do it within 6 weeks.
Wow. So what I hear, one of the indications we have is a compression fracture or a broken vertebrae with damage to the nerve coming off it. We would call that damage. Do you all use that indication?
It's not an indication yet. I have a discussion with our healthcare institute at the moment, and hopefully we get it reimbursed this year.
So this is interesting because it sounds like you do what we call a case conference, where everybody get multidisciplinary, all the specialties you described get together and they discuss the patients and go through the patients. Is that correct?
That's correct.
Wow. See, for us in America, that's done in academics, at the academic hospital. In private practice, that's just not done. Unfortunately, we don't interact with our colleagues that intimately. We call our colleagues on the phone, we send them messages, but we don't have those kind of meetings in private practice. So how long does it take for a patient to get scheduled for case conference?
A week.
Wow, you can do it really fast. So when you said conservative care, I want to make sure we have the same understanding of what that means. What does they didn't do well with conservative care, so how do you define that in your system?
It's basic medication and physiotherapy, possibly rehabilitation, all those things.
Okay, for us, it's injections, anti-inflammatory medicines like Aleve, ibuprofen, Tylenol, and then nerve pain medicines, which would be like gabapentin, most commonly, medications in that class, and physical therapy. Those are what we would qualify for.
That's probably the same.
And they have to have 6 weeks at least of physical therapy. Sometimes it's 3 months. Or a home exercise program that is doctor supervised, alternatively and documented in a very, special certain way. I mean, the exception is cancer pressing on a nerve root when we can prove that. So do you do a lot of spinal cord stimulation in the neck? Because I heard you mention that.
More and more.
Yeah, so I do a lot of that because I'm board certified in headache medicine and I'm actually a neurologist too before I did my training in interventional. So what makes you want to do, what are your indications and how do you think about doing stimulation in the neck?
So the main indication is filled neck, CRPS of the arm, and I'm especially interested in the neck at the moment because of the evolution of the therapy and my idea that with closed loop stimulation, that with one cervical lead, you can also treat foot pain.
With one cervical lead, you could do foot pain?
Yeah, we've done 60 cases now.
Okay, so let me make sure I have clarity. If you put 2 leads in, you could treat neck pain with one lead and low back or leg pain with the other lead. Is that what you're saying?
That's how we start. But then we try to treat everything with the cervical lead.
So for me, I find cervical spinal cord stimulation very helpful for intractable headaches, particularly when they've had neck surgery and they also have a terrible headache syndrome. I find it very helpful. Do you try it in that circumstance?
Yeah, but we've only done 4 or 5 cases. But like what you said,
right. There's not a lot of literature, so my experience is idiosyncratic. There is some literature that about it, but it's a very important area of research that could, would be helpful. So how is your research financed? I mean, you're a government employee, and as part of that, you're able to conduct research. Can you help me understand that more fully?
No, that's always a problem. I need to find money for all the studies. And it's the eternal discussion that I get money from a company, and then everyone claims that the data are biased.
Right.
And I try to get that money as an unrestricted grant, meaning that all the data are with me. And so I do a lot of studies this way. And sometimes we apply for a government grant, but that's very difficult.
Are there adequate monies available from the government? Are those monies, not a lot of monies available for research?
No, there is adequate money. But then to compete for that, I'm just one of hundreds of applicants, and you just need to be lucky to get the money.
So when you say hundreds of other applicants, do you mean people in other specialties different than interventional pain? So it's in the same bucket, and you're all competing. I see. Okay, yeah, this is I hear your problem, because if we accept funds, which we need to do from industry, then we potentially open ourselves up to criticism for bias, which is of course not always true. So it's a tricky problem. Have you done stimulation in the back of the head and the nerves we call the greater occipital nerves? Do you do that?
We do.
And peripheral, on top of the nerves outside of the spinal column, you do it that way?
Only occipital nerve. Because the other indications are not reimbursed.
I'm so glad for you that you have greater occipital nerve coverage. Of course, this is a particular area of interest for me, because I do a lot of interventional headache, and we have very poor coverage for that. 20 years ago, I did a lot of it, but then we lost coverage, so it's a struggle. We're trying to slowly get coverage back. So how often do you do greater occipital nerve stimulation in the back of the head on both sides, and what prompts you to do that?
Probably we do only a few, but we have a small country. We have 26 centers performing SCS or spinal cord stimulation, and one of those centers in Rotterdam. So from the two hospitals where I work, both 45 minutes drive. They are the specialized center for occipital nerve stimulation, and we all work together. So when I have a patient, I call them, I ask them, is it a good patient? What are your waiting lists at the moment? And then if they say it's all acceptable, send them to them. And sometimes they say our waiting list is too long. Please do it yourself.
So is your entire country on the same electronic medical record system?
Yeah. Now we have two systems. But we also have a mandatory registry, meaning that all SCS, everyone has to put all patients in the registry. So we have all data of all patients available.
Yeah, that's so wonderful, the way you can communicate. Our system is very fragmented, and it's hard to communicate across our system, which is not good for the patients. It makes it much more difficult.
Yeah, makes sense.
So have you done any population studies? Because your data, you can just access the data so easily. Have you all?
We're starting with it.
Yeah.
We only have it since 5 years.
Right. That just seems such a fruitful area that is available.
Yeah, it is.
In your country, that is not so much available in America. Of our system. I'm just amazed at how fast y'all can deliver care. How many people live in your country?
18 million.
Right. Wow. How does it? So do the surgeons send you a lot of stuff? The spine surgeons?
No, we work closely together. But spinal cord stimulation is done by 2 or 3 spine surgeons.
You mean the paddle leads? Is that when they?
Yeah, they do some of them. Yeah.
Okay, so most spine surgeons don't do it. Some neurosurgeons are trained, and they'll put paddle leads in. And when somebody has severe scoliosis or something like that, I'll refer to certain people. We find that certain spine surgeons understand spinal cord stimulation very well, and others of them are actually not very well trained in it. So are your spine surgeons, do they understand the role of spinal cord stimulation well?
Yeah, the few that do it, they understand it very well.
So how is the decision made that spinal cord stimulation would be done by the surgeon as opposed to the interventional pain doctor?
Probably by our team. And 99 out of 100 cases, We think we can do it with a percutaneous lead.
Right. So the few, sounds like a small percentage need surgical placement. What kind of candidates go for surgical placement?
Mostly patients where we had problems with the percutaneous lead. So migrations, something.
Yeah, that's how I do it. Like I said, I don't have case conference. I'm a private practitioner, so it's basically my judgment. If I have trouble getting the leads in the trial, I refer it to like the one or two surgeons I know, that the neurosurgeons for us, that will do a paddle lead. They'll drill a little hole in the bone and slip the paddle in there.
Yeah.
But yeah, I just use my judgment when I think it's going to be difficult for me to get it back in there the second time, or if I couldn't even get two leads in. Sometimes I can only get one lead in, and it's better for the patient to have two leads because they get better coverage. But I'll sometimes proceed with a single lead trial in difficult anatomy. And if the patient does well, I'll send them to a surgeon. Yeah, how much of your day do you spend coordinating with other practitioners, like percentage-wise, 15, 25? Like, how much of your day is spent doing that, coordinating care?
Probably 10-15%.
Okay, that's good. It sounds like you'll do it very efficiently. So you just send messages occasionally, and then you have this case conference. Is that how it works?
Yeah.
Wow. Yeah, this is very efficient. I'm impressed. But your country is small and everything's close together.
That's the advantage.
Right. Yeah, I mean, of course, it's just so huge for us. And people have to travel a long way to big referral centers because a lot of America is rural, and we can't have specialty care in rural places because there's just not enough people, doctors, to do the kind of care. And in those rural places, there's not enough patients, so they're forced to come into the referral centers to get the care they need. That's a big structural problem. I have no idea how to solve it.
It is, and in the Netherlands, I think every inhabitant has a hospital within 10 minutes.
Wow. Yeah,
That's different.
Yeah, it's wonderful for the patients, of course, because it's safer for them. They can get quick care. And, because our country is so vast and a lot of it's rural, that's just not available to many people, because of, the rural nature of a lot of our country. I'm impressed. What do you think, what haven't we talked about that you'd like to add?
No, the only thing would like to add is that internationally we should work more together. Learn about each other.
I totally agree. Now, this year, one of the international pain conferences is in Amsterdam.
Yeah, I'm organizing it.
Yeah, I wish I was coming, but I have to tell you that the New Orleans Saints, our football team, they're playing in Paris. So actually, my husband has French roots. We're going to Paris to the game and to see his extended cousins there. If not, I would be at the conference. I hope to come next year. Yeah,
should do. Next year's in Germany.
Wonderful. Which city?
That should be Berlin or Munich.
Oh, I definitely plan to be there next year. Yeah, and then we do have a lot to learn from each other and the differences in the systems, the way our systems work. I think we can have a fruitful exchange. Of course, I have such a strong interest in interventional headache and cervical stimulation, and I wish we could find a way to work together to create more data, because the way our system works, if we don't have a lot of strong studies, the patients are denied that care because it's deemed experimental by the standards of the insurance company. So
Same with us.
we create data, and then creating data is so expensive. So it's really tricky. And as we advance and get better and better, and we understand the mechanisms, we know these things work, but we haven't built these big data sets, and that hurts the patients. Yeah, I think we can chip away at that to improve access and care for the patients, definitely for us, and it sounds like even for you and the European Union also, because you can create a better data set. So let me ask a kind of a regulatory question. Do patients not have access to certain care because there's not enough studies? Like, how is care evaluated?
Yeah, that's a big discussion in the Netherlands. Our healthcare institute, they are the boss.
Yeah.
And they decide if there's enough evidence to get something reimbursed. So actually, at the moment, I'm fighting with them to get non-surgical low back pain with 4 RCTs, a systematic review in spinal cord stimulation,
Yeah.
but also the BVNA ablation, multifidus stimulation, to get them reimbursed. But that is tough.
It's tough. So what, just to translate it for more the general audience, some people have severe back pain and they haven't had surgery. That's non-surgical low back pain. Maybe they can't have surgery because they're sick or other reasons. Those people do benefit, in my opinion, also, and there's data to support
I agree.
that. And then I also heard you say the procedure where we burn the nerves inside the bone itself, you're trying to get coverage for that procedure, which is a very strong procedure also. Yes, and an area where we have poor coverage is treatment of the disc. It's when we inject into the disc in the low back, and I did see you published on that. Only one insurance, our Medicare, will cover that, and I find it very beneficial. So we're also struggling to access care for the disc procedures for our patients. Yeah, so we'll continue to push forward on that incrementally.
We have to.
And yes, for the well-being of our patients, absolutely. Okay, well, just thank you so much for taking the time to be with me today. Thank you.
Good, thank you.
Okay, can you hold on a minute so we can upload it? So when my people get this edited, I will send you a link to it so you'll know. And I don't know, do you have social media? Do you do this? Do you post stuff?
I can post it on LinkedIn.
Yeah, so that you can have an opportunity to post it. So I guess you guys don't have to advertise because you're all employed, right? So a lot of us, we have sites where we advertise so patients can directly refer into us. Like that's what I have.
All right.
Yeah, because they self-refer. And what I didn't talk about is, and this didn't happen in Europe because they'll handle this better, but particularly when I first got out, people were terrified, this 25 years ago, they were terrified to come to pain doctors because we were in the opioid crisis and they thought all we did was give opioids. That's not what we do, but they didn't know. They were so afraid to come. But now they understand, most people understand that there's doctors like us that we give injections and work on the spine, and then there are still people that give opioids, but a lot less of them. So I know Europe didn't endure the opioid crisis that we have, and I'm glad for you. Yeah, I think those days are over. A light has been shined on that, and in a good way, right? Well, I look forward to meeting you in Germany.